first paper is Neuro-ophthalmic disorders associated with COVID-19 infection by Dr. Vidya.
Timer, yeah. Okay.
Good morning, everyone. So my topic for presentation is neuro-ophthalmic disorders associated with the COVID infection. So COVID pandemic has involved almost all the countries of the world, and it is a respiratory virus that ends up affecting all the organs of the body, leading to the various manifestations. Our study is a retrospective study of the records of the patients who present to our hospital from January 2020 to July 2021 with a history of COVID infection. We have excluded the patients who presented following the vaccination. So 16 patients were diagnosed. We divided them into 5 categories depending on the site of involvement. So category 1 is a pupil-related condition. Here 3 patients were identified. All the 3 patients had an unilateral AD's pupil features, and they were given the near addition or the progressive glasses. Even after 2 years of follow-up, they ended up showing the same pupil features in the affected eye. Category 2 is the retina and the optic nerve condition. Case 1 is an 8-year-old child who presented with a bilateral optic disc edema as shown in this picture. And she was referred to the neurologist and diagnosed with a multisystem inflammatory disorder. And case 2 is the 24-year-old male who presented with a sudden onset of diminution of vision. And he had a right eye rhegmatogenous RD due to a giant retinal tear, which was pre-existing. And left eye, he had a neuroretinitis following the COVID infection. Case 3 is a 35-year-old male who presented with a sudden onset of blurring of vision. He was diagnosed with a retrobulbar neuritis in the right eye, and he recovered following the IV steroids and the oral steroids. Category 3 is a cortex-related condition. Here we had 4 patients. 3 of them were the adult patients who were in the mean age group of 65 years, who were having the cortical vision loss. 2 of them had a parieto-occipital lacunar infarcts, and 1 had an infarct in the right PCA territory. All of them ended up having a residual visual deficit even after 2 years of follow-up. Then 4th is a 1-year-old female child who presented with the history of not following light even after, following the COVID infection. Rest other features were normal. The child had a parieto-occipital gyral thickening along with the hypoxic changes. The child was diagnosed with a CEYI associated with the COVID-associated encephalopathy and advised the vision stimulation exercises. Category 4 is a cranial nerve-related condition. We had 4 patients here. 2 of them had a 6th nerve palsy and 2 of them had a partially involved 3rd nerve palsy. As shown in this picture, this is a case number 10 who presented with the left eye 6th nerve palsy, and case number 8 who presented with the right eye partial 3rd nerve palsy. Case 5 is a miscellaneous condition. Here, a 56-year-old male who is a known patient of multiple myeloma on a quiescent stage for the past 5 years' time, who presented with a sudden onset of forward protrusion of the right eye with a limitation of movements following the COVID infection 1 month back. And he was sent to the neurologist and diagnosed with the aggravation of the multiple myeloma. He was again treated with a chemotherapy. Then the second case is a 44-year-old male who was a known case of a small pituitary adenoma for the past 8 years' time. Following the COVID infection, he showed the diminution of vision. He was diagnosed with a post-COVID aggravation of pituitary adenoma and advised for the neurosurgeon opinion. So coming to the discussion, the COVID infection can present, ending up with so many problems in the eye, the ophthalmic manifestations. The mechanisms involved being the vascular thrombosis, direct involvement of the CNS via the ACE receptor, and the virus-mediated immune responses. Lee et al. Has reported 36% of the patients ending up with the central nervous system problems. Zhou et al. Reported MOG, antibody-associated optic neuritis in COVID infection. Oritz et al. Has reported a bilateral 6th nerve palsy following the COVID infection. And Sir et al. Has reported 2 patients of severe bilateral vision loss following the COVID infection. Oritz et al. Also reported a case of bilateral AD's pupil following the COVID infection. Then Miller-Fisher syndrome and delayed onset of ocular myasthenia has also been reported in the literature. The limitation is in our study is that we haven't done the CSF analysis for all these patients, so we cannot prove the causal relationship here. Of course, associated comorbidities also need to be considered in these patients. So I conclude by stating that the COVID can affect from the pupil to the brain any part here. The cranial palsy is recovered almost completely within 3 months' time, but the cortical vision loss tend to leave a residual visual defects. And aggravation of the tumors and blood dyscrasias were found to be associated with the COVID infection. So further research is needed to establish the causal relationship between the COVID and the neuroophthalmic manifestations. These are my references. Thank you.
Nice presentation. Did you find any correlation with vaccination?
Of course, ma'am, but we have excluded in this study here. We have a separate study done for that.
So, any correlation with other risk factors like diplopia, sixth nerve and third nerve?
Yes. The patient presented with the diplopia, sir.
No, they had any other.
Of course, they
vascular-
had the associated microvascular factors like diabetes and hypertension, but they were having that for the past 10 to 15 years' time, but only following the COVID, they ended up this. So we were not able to find out whether it's due to the COVID or the aggravation of the microvascular etiological factors.
So 2-year follow-up is already there.
Yes, 2 years follow-up is there.
Unlikely to recover after
Yes.
2 years. Yeah.
Cranial nerve palsy is recovered completely, but the CVI patients didn't recover completely.
Okay. Thank you.
So do you think this is the infectious component or the inflammatory component?
Sir, in few patients, in CVI patients, we found it's an immune-mediated responses. Of course, we have not done the CSF analysis just to prove that it is an infective component, which is the reason here. We haven't done that.
Most likely will be the inflammatory, like you're saying, because
immune-related. Yes.
Arun?
Yes, yes.
On established and emerging risk factors of non-arthritic anterior ischemic optic neuropathy. Timer, please.
Good morning. So my topic is non-arteritic anterior ischemic optic neuropathy, the assessment of its risk factors. So first I would like to tell you why we did this study, because there is no proven treatment and no elaborate pathophysiology that is established. So there is also a recurrence in the fellow eye and in the same eye. So only chance the patient gets to prevent the recurrence is the modification of the identifiable risk factors. So far a number of risk factors have been identified and the list is endless, and with every upcoming study there is one more new risk factor which is being added, and our special interest was in hyperhomocystinemia. So before I go to the study, I'll tell you why this hyperhomocystinemia occurs, and this is a pathway where methionine transsulfuration pathway in which the homocysteine accumulates, and it actually is a free radical which actually causes a hypercoagulable state which has been established in retinal vein occlusions, myocardial infarction and stroke. So now we are finding it in relation with the NAION itself. So the homocysteine that accumulates, either it's recycled back to methionine or cysteine. If that doesn't happen, then hyperhomocystinemia occurs, which is actually related to NAION when there is a mild or moderate elevation. When it becomes a severe elevation, it becomes homocystinuria, and that occurs only in when there is an inherent genetic defect in the enzymes involved in this pathway. So this hyperhomocystinemia occurs due to the deficiency of the FACO factors, basically B12, folate and B6, which are mostly due to the dietary and environmental factors. If you ask me, is hyperhomocystinemia something new? Yes and a no. Yes, in the sense in the Indian scenario, it's not being well analyzed, and in Western scenario, it has been analyzed, yes. So why is it relevant in the Indian scenario? Because even the healthy Indian doctors were found to have hyperhomocystinemia without any pathological events, and the dietary differences are there between us and the Western population. So that is why we went on to do a retrospective analysis on 63 patients who were newly diagnosed with NAION over a period of 6 months, and we analyzed the already established risk factors, blood parameters as a routine, and we did the carotid Dopplers and fasting serum homocysteine levels. So, and we also recorded the visual acuity, visual fields, and the other eye cup to disc ratio, and we only included the new or acute onset which is within 2 weeks, and we excluded the arteritic AION patients. So here are our results. We had 63 patients, of which 12 had lost to follow-up. The mean age was 55 years, and 8 patients had a previous history of documented NAION in the fellow eye, and there was a male predisposition. All our frequencies were comparable to the literature that is already published, and patient presented to us with a mean visual acuity of 624 and altitudinal scotoma as the most common defect that was noted. So all of even this was comparable, the investigations were comparable to the literature, but only thing is we had 20 patients turning back to us with carotid Doppler, of which 50% had an increased intimomedial thickness in the common carotids or its branches, and of the 16 homocystinemia patients who came back to us with homocysteine levels, 8 were found to have it elevated. And then we did a subgroup analysis of 8 patients with second eye involvement had diabetes, which is a proven risk factor, and we also had 2 patients with hyperhomocystinemia. And of the 8 patients who had hyperhomocystinemia in our study, 2 were less than 50 years, and 1 patient had no systemic comorbidities. The third patient, he also had a moderate elevation of homocysteine levels, whereas others had a mild elevation. We also analyzed the vision if it was correlating with the improvement or worsening with various risk factors and blood parameters. However, there was nothing. And as I said, the literature, our study frequency is comparable with the literature, even though the literature does not show any association of carotid thickening, but our study has a significant frequency. If the other established risk factors are comparable, then this would also be a true one. And we could not establish the relative risk that hyperhomocystinemia attributes to NAION, as we did not have a control group, and other limitations were retrospective design, and we only did a fasting homocysteine and not a methionine load test. So to conclude, our study results are comparable with the published literature of all the established risk factors, and we also found a relation of the carotid thickening and the hyperhomocystinemia within the NAION patient, but we would further like to determine the relative risk by doing a prospective case control study. So thank you.
Thanks, nice presentation. Did you include sleep apnea disorder patients in this?
No, ma'am, that we could not evaluate because of the financial
History also you didn't
constraints.
ask about that?
History, not much was there, ma'am.
Because that is another important factor
that's
these
not-
days, we found, when other things are negative.
See, while you were presenting, you made a passing remark of our diet being different from the Westerners. What is there in our diet, or what is not there in our diet?
The vegetarians, they usually lack the B12, and the non-vegetarians, they lack folate, and folate has been found to be the major risk factor which has been associated with NAIONs. So in that way, our cofactors are still to be analyzed if there are patients with hyperhomocystinemia, so that we can supplement them and we can prevent the other eye involvement. So that is what we feel, that dietary and environmental factors are much relevant in the Indian setting, and it is different from the Western.
Yeah, nice presentation. We cannot definitively say that this is hyperhomocystinemia because of the other risk factors present.
Yes, sir.
How many cases you had only with hyperhomocystinemia?
That was one case which
Only
had a
one
moderate
case.
elevation. Others just had a mild elevation. But then I think the diabetes status and the other systemic parameters were mostly controlled. They did not have a increased blood sugar level or a dyslipidemia, anything during the presentation. So mostly it was hypohomocystinemia, which was...
And any other thrombotic risk factors, like those rare congenital thrombotic risk factors?
That we did not
Protein
analyze.
is-
Protein C, protein
nothing,
that we
nothing.
did not
Okay.
analyze.
Thank you.
You've been talking about the risk factors. How long have you had a follow-up of these patients? Why I'm asking you this is I'm interested to know that if the risk factors are controlled, do the field effects improve?
We had only a 3 months follow-up, so we couldn't make out much of it, sir. So that's why we just did a visual acuity comparison and not a visual field comparison.
That is a
First of all, thank you, Chairperson and judges, for adjusting me. I have a talk in the other session, so very kind of you. Thank you. I would be speaking on an interesting case which had 2 components. So it was a little dilemma, depending on the diagnosis and the management, what was going on. This patient was on antitubercular treatment, and she presented with a gradual onset fast progressing vision loss. So initially it was a gradual, but later on it was quite a fast progressive vision loss. And she was like about 26-year-old. So this is a 26-year-old female with pulmonary tuberculosis, and she's been on ATT for the past 3 months. She comes to us with a bilateral gradual vision loss, which was over a period of five weeks. It was deteriorating. She showed at a local hospital, and then she was diagnosed as optic neuritis and given pulse of IV methylprednisolone for 5 days, which is the usual treatment what we give. She had no improvement in vision till 2 weeks and was then referred to our center. So when she presented to us, she had a vision of finger counting close to face. Her color vision and contrast sensitivity were decreased. So if you see here, I mean, these are the disc when she presented to us, and there is little hyperemia of the disc if you notice here and here, but otherwise the vessels are fairly well delineated. So when we did a visual field besides the color and contrast, what we can see here is you can see the sequocentral scotomas in both the eyes. The left one is really worse as compared to the right eye. So what happens further now? She has no pain on extraocular movements. She has no improvement with intravenous steroids. She was diagnosed with optic neuritis. Now, an optic neuritis patient, if it's atypical, then there is a possibility that the patient might not improve with IV methylprednisolone. But she has a history of ATT. She has a gradual vision loss. She has bitemporal sequocentral scotomas, possibility of an ethambutol toxicity. So here now we stopped the ethambutol. So what happened further? Then we did the visual evoked potential, because again she was diagnosed with optic neuritis, but we stopped ethambutol considering the visual field and a gradual loss. So when we did the visual evoked potential, we found a decreased amplitude. Now decreased amplitude goes in favor of an axonopathy, that is a mitochondrial dysfunction which the ethambutol strikes. An optic neuritis would have latency because it's a demyelination. So here again it favors an ethambutol toxicity, but there is GCL loss, which I'll just show you. Now, at 2 weeks further, we've stopped ethambutol, but there is further deterioration of vision. Now we stop INH here. But again, she presents because we're having a close follow-up. At the next close follow-up, the vision goes down. Now, because she has no improvement, obviously we have to order an MRI. We order the NMO-MOG antibody titers and repeat the pulse methylprednisolone. So after a few days, after getting 5 doses of methylprednisolone, there is some improvement. She comes back with an MRI which has enhancement in the retrobulbar region, which is suggestive of optic neuritis now. Her anti-MOG antibodies come out to be positive. So after she regains vision of counting finger 3 meters and 660 in the left eye. After a pulse methylpred, she shifted on oral steroid with slow tapering. Now this is the severe GCL loss which is coming up. Probably now this is again now favoring an optic MOG and optic neuritis. But she has no RNFL loss here. So what happens after 4 months? We are following her for now, treating her for MOG antibodies. We stopped her ATT. The visual acuity further improves, and after 4 months, she reaches almost 6/6. So she presents with counting finger in both eyes and reaches 6/6. The visual acuity, the visual fields just have a central scotoma. The anti-MOG antibodies were repeated, they were negative. So basically, she had an ethambutol toxicity initially, and which was superimposed with the MOG positive optic neuritis with no brain demyelination. And she does have these central scotomas, but yes, these have decreased as compared to the initial presentation. So we have a double trouble, an ethambutol toxicity probably, and a superimposed optic neuritis. So I would like to conclude here by saying that patients on ATT with a progressive vision loss should be worked up in detail. We should keep a high index of suspicion for optic neuritis in those with rapid worsening despite stopping ethambutol. And imaging and blood titers of optic neuritis should be carried out in all these patients. And the treatment should be in close collaboration with the pulmonologist, neurologist, as the chances of visual recovery are good. And so in this case, probably, had we not got further investigation, just harped on the ethambutol, she might have recovered, maybe not to that potential, because it was a MOG antibody optic neuritis. And so we had, because of this intervention, she did well. She just presented to us a month back. That's 2 years follow-up. She still maintains a 6/6 vision. Thank you so much.
Thank you, Dr. Jasprit. Nice, interesting case. But one point, why she didn't respond to initial IV methylprednisolone?
Yes, that is a big question. That was the question which came to my mind also. Probably it could be just a subtle improvement in vision because, as I said, how closely were they monitoring the vision? It could be just a mild improvement. But yes, when she presented to us as well, she had a severe visual loss of counting finger 3 meters.
Maybe those were not sufficient.
Could be that thing. But again, when she presented to us, the features were what she presented to us was an axonopathy on VEP, a bitemporal centrocecal scotoma going in favor of a chiasmitis. So I mean, it was like a dilemma coming up until we got an MRI done.
Fundus examination is also very important because
Absolutely.
in ethambutol usually we get normal or slightly pale disc.
Slightly pale, but she was
slightly hyperemic.
Yeah, slightly hyperemic, but she presented after 2 months. I mean,
maybe
it's a very variable thing.
So
yes,
fundus examination
Absolutely.
clinical is very important.
I showed that fundus exam. That's why, yeah.
So that is a point I wanted to make. Retrospectively, if we think of that fundus picture,
Yes.
then maybe
Yes.
one
Could be, absolutely. I mean, I don't disagree. Absolutely, this could be a part of it. But ethambutol also sometimes in acute presentations present of this picture with a nasal blurring. It does present. And then probably you might think of giving them IV methylprednisolone. But this patient didn't improve or improved just slightly. So that's a big confusing part when she presented to us. Pupils were, there was no RAPD. But obviously the pupils were reacting, maybe not that brisk, but I mean, you could not say that it's an abnormal pupil. Yeah. You could guess if it's a severe optic neuropathy. If the optic nerves are thinned on probably on MRI, yes, you could.
You can also get a delayed response to IVMP. Delayed response to
Yes, I mean,
methylpred. You may not get that immediate response.
could be, yes, sir, no doubt. I mean, delayed response, but in case of, if we like, this patient was MOG antibody positive. So, I mean, these are steroid responders.
Yeah.
So, she should have responded to a steroid. Had it not been a MOG antibody, yes, sir, I mean, there could be a delayed response.
Okay.
I have a comment.
Just brisk comment. Just brisk comment.
I have a comment and a question. The comment is the presentation is looking at the patient only as an optic neuritis. One. The second thing is a question. You've stopped. We have stopped. Or you have stopped ethambutol and INH, and you've added high dose of steroid, which was tapered. What happened to the pulmonary component of the whole patient's
Absolutely,
disease
that's
process?
why my last line.
This is something all of us have to think about because we are going to deal with the patient. You stop all this. How did the pulmonologist allow? I'm curious to know what they substituted INH and ethambutol with. The second point is ethambutol toxicity. The improvement is going to come very slowly.
Yes.
We have to stop the ethambutol, start B12 and high doses, keep them on B12 and rest and wait. That is what we have seen. Sometimes improvement takes months, sometimes even years. So just saying with a 2-month follow-up that the patient did not improve does not mean that your treatment has not improved the patient.
Yeah.
So these are 2 points to consider. I'm really curious to know what the pulmonologist did
absolutely.
about
So
the
that pulmonologist, what
disease.
that pulmonologist did, I don't have an idea because obviously that's why my last sentence was that has to be done in collaboration with the pulmonologist. What treatments, how they manage these things. I mean, they are case-to-case managements. I mean, it's not that common that you're going to give IV methylprednisolone, but yes, there was a close consultation with them. And what management she took, I don't know. I mean, she did resolve. The other thing is, I mean, ethambutol no doubt takes sometimes in few cases it takes maybe 2 years also. The maximum time has been shown to be 2 years when the patient has recovered. But yes, a continuous progressive loss of vision after stopping ethambutol and a fast progression should not be there. It should be either be static or maybe just a slight tapering loss of vision. But here, with the rapid response to steroids, we have to consider this condition the second condition of optic neuritis because the way the patient responded. So these things have to be kept in mind. We can't just be going on telling just one line that yes, it might take longer. We have to intervene considering the clinical parameters.
Thank you, Dr. Jasprit. Thanks for the discussion.
This one, no?
You want
So we get extra time for discussion. We get extra time for discussion.
Yes. Yeah. Good morning, everybody. I have no conflict of interest to declare. As
It's not visible here.
papillodema.
Excuse me, it's not visible here. Not visible.
Shall I start? Like this.
Yes, you can start.
Yeah. I have no conflict of interest to declare. As papillodema is the most ominous sign in neuro-ophthalmology, so diagnosis of papillodema carries with it a heavy responsibility. Knowledge of common causes of papillodema in certain underdeveloped area guide us in early diagnosis and cost-effective management. That's why an attempt is done to study the various causes of papillodema in pediatric age group, that is below 18 years, according to Indian Association of Pediatrics in northeastern India. It was a hospital-based prospective study. 170 consecutive patients referred to ophthalmology department of Nazarat Hospital having papillodema as fundus finding from January 2011 to December 2021 were studied. Detailed history, thorough clinical examination, and neuroimaging were done in all cases. Other investigation like lumbar puncture or CSF study were done wherever it was indicated. Cases were followed up to a period of 3 months. We divided the cases into 3 age groups: 0 to 3 years, that is preschool children, 4 to 12 years, that is pre-adolescent period, and 13 to 18 years, that is adolescent period. Most of the patients were presented with headache, fever, and vomiting. Visual symptoms like transient obscuration of vision and dimness of vision were also present in some cases. Among associated ocular findings, most common was lateral rectus palsy. Most common etiology of papillodema was found to be of infective origin, followed by space-occupying lesion. Autogenic.
Just
wait.
Just.
It's gone.
Most common etiology of papillodema was found to be of infective origin, followed by space-occupying lesion. Autogenic intracranial complication, that is, intracranial complication arising from middle ear infection, was present in 18 cases. There were 14 cases of pseudotumor cerebri and 8 cases of hypertension. Among various causes of infective etiology, most common was tuberculosis. CSF analysis revealed high lymphocyte count, high protein level, and low sugar level among them. Viral infection of central nervous system in the form of viral encephalitis and meningoencephalitis found in 20 cases. There were only 3 cases of fungal infection, as the weather in the study location is relatively dry and cold. Among space-occupying lesions, most common was tumor and tuberculoma. Intracranial hematoma following trauma were found in 10 cases. There were 6 cases of brain abscess and 6 cases of neurocystic sarcosis. Now I want to show some CT picture showing space-occupying lesion, starting from extradural, subdural, subarachnoid, and intracerebral. Then here tuberculoma in the upper 2 CTs picture, multiple tuberculomas in the lower one, single tuberculoma surrounded by perilesional edema. Then brain abscess. In the second picture, it is a multi-septed brain abscess. Then brain tumor, mostly located in the posterior part of the cranial fossa. Then neurocysticercosis. In the upper two picture, cysticercal cyst is located in the third ventricle, obstructing the outflow of CSF and thereby dilating the ventricles. In the lower two picture, the brain matter is studied with multiple cysticercal cysts. While analyzing the various etiology in different age group, we saw that in 0 to 3 years, most common etiology was infection. In the second group, space-occupying relation was the most common etiology, whereas in the third group, the incidence of various etiology were almost same. Earliest regression of papilledema was seen at the age of 1 month. It was maximum in cases with infective origin. 25 cases died during the study period due to disease. The mortality rate was highest in cases with tumor, and in cases with infection, it was relatively less. Discussion: brain damage in tubercular meningitis is the consequence of marked tendency towards granulation, exudation, and fibrosis of basal exudate. The site of tumor is more important than its size, nature, and rate of growth. Pseudotumor cerebri is also an important cause of papilledema. The limitation of this study was the presence of papilledema was assessed subjectively. So we may miss some cases of early papilledema or may misdiagnose some cases of pseudopapilledema as papilledema. Conclusion: the important findings of this study was: number one, tuberculosis is the most common cause of papilledema, either in the form of infection, that is tubercular meningitis, or in the form of space-occupying lesion, that is tuberculoma. Number two, complication of middle ear infection is an important finding of this study, as the study region is located 5,000 feet above the sea level. In that altitude, the complication of eustachian tube blockage, middle ear infection, and subsequently intracranial complication is high. And number three, the most interesting finding of this study is neurocysticercosis as a cause of papilledema, as the study population is tribal dominated. Their habit of taking smoked pork, and therefore the incidence of cysticercosis, neurocysticercosis is very high among them. Hope this study will shed some light in diagnosis of papilledema and early management in the underdeveloped part of India. Thank you.
I think this is an excellent study coming from Northeast India. There's just two points that I will want to make. Obviously, you may be looking at getting this published. I want to know, have you measured the opening pressures when you've done the lumbar puncture? Because you haven't mentioned that.
No, sir, actually I mentioned that these cases were referred to ophthalmology department from other departments. So lumbar puncture I haven't done.
Yeah. Okay. So then I think it may be pertinent that you change probably that word papilledema and make it disc edema, because you are basically talking of disc edema. You may have certain cases which may actually be optic neuropathy.
Yes.
Or optic neuritis, because what you're getting is the highest is the infections.
Yes.
You're getting highest incidence is tuberculosis, the middle nerve, the middle ear infections. Probably those are cases which are of optic neuritis or optic neuropathy. So it may not be a good thing to call them as papilledema, because classically when someone tells papilledema, I would think of raised intracranial pressure.
So they are having that headache, fever, vomiting and all is going towards papilledema.
I mean, that it was confirmed diagnosis of papilledema. That's what you want to say, no? It's
Yes.
about a confirmed diagnosis of papilledema.
No, sir.
Ruling out other
I told that
neuritis and other causes.
that limitation of this study, ma'am, we may miss some early papilledema or papillitis may diagnose as papilledema, because it was done subjectively by only one person, that is me. So that was the limitation of this study.
Yeah, but you have a 11-year follow-up, so that's a good part of the study that you have.
And any documentation on how early they were diagnosed, these papilledema? How much was the delay in that part of the country? Generally, some of these cases are
Yes.
diagnosed very late. So
Yes,
have you noted any, delay in diagnosis of these cases? Delay between onset of symptoms and diagnosing a papilledema.
Actually, sir, my hospital is a mission hospital. So patients were admitted in the hospital with this problem. Then they were sent to the eye department. All the children, they are having children with headache, vomiting. They cannot do CT scan for these children. And radiology contraindicated. So before doing CT and all, they are sending maybe the refractive error, maybe the cause. So when I saw it is papilledema, I just tell them just do a neuroimaging before anything else. Then so we make a rule of just discharging a patient from the hospital thinking as a refractive error, and when I got it papilledema, they have to do the neuroimaging and all. And cases were happened that they are ready to discharge the patient, they just send for before discharge that do a refractive correction, and I saw papilledema. Next the patient was operated by neurosurgeon. These are the cases happened like that.
And you mentioned about transient blurring of vision.
Yes.
Did you get any transient diplopia in these kids?
Transient diplopia, it was dear, sir. Diplopia because most of the patients were present with lateral rectus palsy. Okay. The patient diplopia was dear.
Some of these cases are meningitis.
Meningitis.
Good morning, everyone. Rhino-orbitocerebral mucormycosis, presentation and radiological staging of 8 cases. Rhino-orbitocerebral mucormycosis, or ROCM, is a potentially lethal angio-invasive fungal infection which became a matter of concern during COVID-19 pandemic. The anatomical and radiological involvement varies from each case and it determines the outcome also. Thus, Honavar et al. Proposed a 4-stage system to determine the anatomical extent and severity of ROCM. These are few images of stage 1 which involve nasal mucosa, stage 1A with middle turbinate, 1B with inferior turbinate, 1C with nasal septum involvement and 1D with diffuse nasal mucosal involvement. These are images of stage 2 which involve maxillary sinus, that is stage 2A with 1 sinus involvement, stage 2B with more than 2 ipsilateral sinus involvement, stage 2C with more than 2 ipsilateral sinus involvement with or without hard palate and cavity, stage 2D with bilateral paranasal sinus involvement. Stage 3 include orbit involvement, stage 3A with medial orbit, stage 3 with more than 2 compartments in the orbit and visual normal, stage 3 with superior orbital fissure or inferior orbital fissure or orbital apex involvement with ophthalmic artery, central retinal artery or superior ophthalmic vein thrombosis. Stage 3D include both this orbital involvement. Stage 4A coming to central nervous system involvement, 4A with focal cavernous sinus thrombosis, stage 4B with diffuse cavernous sinus thrombosis, 4C with internal carotid artery occlusion and focal brain infarct, stage 4D with diffuse central nervous system involvement. Our objectives was to understand the anatomical and radiological correlation in ROCM cases and to highlight the need of teamwork with radiologists in diagnosing and beating this black thread. It was a retrospective study we conducted in our tertiary eye care center during the duration October 2020 to December 2021, including all the patients with either diplopia or drooping or probable ROCM and excluding patients with diplopia from ischemic and traumatic cases. We did a detailed history including systemic history, refraction, color vision, pupil as well as neuro-ophthalmic evaluation, and we did radiological staging from MRI. Coming to our results, 87% of the patients were male with a mean age of 57.8 years. And the risk factors commonly being diabetes mellitus, COVID positivity, and patients on systemic steroid. Blood investigations of 4 patients revealed raised blood sugars and ESR and 2 with borderline blood sugars. The varying visual acuity was from no PL, hand movements, and up to 6 partial. And the chief complaints were drooping of lids in 3 patients, fever and nasal blockage in most commonly. And this is a clinical feature of a patient who came to us. The isolated nerve palsies, there were 3 patients, one with 6 nerve palsy, one with incomplete third nerve, and one with pupil involving third nerve. All other 5 patients had multiple cranial nerve palsies. MRI, brain and orbit contrast of all these patients showed variable severity and all were diagnosed as fungal etiology. Out of our 8 patients, irrespective of their COVID status or the diabetic status, all the stages were in stage 3 or stage 4 and none of them came to us in the initial stages. This is a MRI image of a patient who came to us with superior third nerve palsy with V1 involvement, showing mucosal thickening in the ethmoidal and frontal sinus along with mildly edematous medial rectus muscle. This is a MRI image of a patient who we unfortunately lost the patient who presented to us in stage 4 with ICA thrombosis in right side. The imaging manifestations of all the patients showed thickening in the sinus mucosa and inflammation of periorbital muscle. There were 2 patients with cavernous sinus involvement, ICA occlusion in 1 patient and cerebral involvement in 3 patients. All these patients since need a urgent referral to neurologist and ENT for expectant management. 4 of them on further follow-up showed full recovery after surgical intervention and with liposomal amphotericin B. Unfortunately, 1 patient was succumbed to death and 3 was lost follow-up. Mucormycosis is a rare filamentous fatal fungal infection mostly encountered among immunosuppressed patients. A drastic spike of cases were there during COVID-19 pandemic. Since it may involve the orbit and other ocular structures, the ophthalmologist may be the first to see the patient with this highly comorbid condition. In our case series, it was suggestive that MRI was helpful in the management of ROCM, which guided us to diagnose the pathways of spread, diagnosis, prognosis, as well as follow-up. The mean age of presentation was in concurrence with other study. The sex predisposition, predisposing factors, as well as clinical features were all in concurrence with similar studies. The patient who are under regular follow-up with good recovery showed that the importance that early diagnosis, aggressive surgical debridement, and antifungal therapy is a key to improve survival in ROCM. Coming to conclusion, ROCM being a rapidly progressive disease with hike during this COVID era, we the ophthalmologists receive most of the clinically suspected cases. In suspected patient with ROCM, demonstration of possible causes with spread, angioinvasion and necrosis by MRI forms the cornerstone in management, and the urgent interventions by us and the radiologist alongside the multidisciplinary team can definitely make an impact in the outcome and recovery of ROCM patients. These are my references. Thank you.
Nice presentation, good collection of cases, and the record of this MRI findings were really interesting. So early diagnosis is the key to save the eye, and that was a responsibility of ophthalmologists.
But all the patient came to us in late stages.
Stage, that's what I'm saying, at the nasal level if it is stopped. Perineural spread is also there, so can you find any suggestive finding? Like
1 patient had it was noticed that RBN, but it was not suggested in MRI imaging, like 1 patient.
Vascular etiology and direct spread was more seen.
Yes, madam.
Just a comment. You're not a ratified member, so I'm just taking the liberty of making a comment. I don't know what is anybody else's experience here. Have you all used the MRI during follow-ups?
During follow-up...
See, I agree with what you're saying. There's no doubting that. I want to know, have you used MRI during follow-ups? Why I'm asking you this is because we've used MRI during follow-ups. And we found that while it is a very good tool to diagnose and treat, but in follow-up somehow MRI does not show resolution. I mean, MRI continues to show some issues while the patient is fine.
It was like 2 or 3 patients on follow-up. It was like continuing progression. It was showing in repeat MRI also. Patient was referred who were under follow-up showed continued progression. Even with patient like with no PLI and all, the MRI features was suggestive that it was progressing, like continuing progression of the...
So what we found in our series, we had 26 patients, that the patient got fine, was cleared by the ophthalmologist, was cleared by the ENT people. But the MRI continued to show that.
It was similar like that only. One of our patient, it was like CNS involvement MRI showing that progression is there in repeat MRI. One of our patient who lost the vision, no PLI, that patient on follow-up.
Hello. Ethambutol-induced optic neuropathy. So why it is a conundrum? So let's discuss. Good afternoon, everyone. So as we all know, ethambutol is one of the drugs that is used in the treatment of tuberculosis. It causes oxidative, it basically disrupts the oxidative phosphorylation that increase the reactive oxygen species and cause apoptosis of the cells. So why we choose this study? Because retrospectively from the data from the tertiary care hospitals in South India, we found out that the incidence has been increased since 4.4% to 12.7% in last 4 years. So according to the revised National Tuberculosis Control Program, they have updated the regimen to daily dose, fixed daily dose regime of ethambutol for 6 to 9 months. So our aim is to study the presentation and the prognosis, and to study the visual field effects, VEP changes, and the MRI findings in these patients. So we studied the 30 patients coming to the OPD of our hospital. It was a retrospective observational study. We included all the patients above 18 years of age and those on ethambutol between 15 to 25 milligrams per kilograms per day. And we excluded all the patients having retinal or optic nerve disease. We studied all the patients coming to us between January to March 2022 with bilateral painless loss of vision. And we examined the patients, and the detailed ophthalmic evaluation was done. We discontinued and replaced ethambutol with vitamin B supplements and zinc. And we took follow-up at 1 month. And we found out that the mean age at presentation was 53.7, and it is higher in females than males. And our study was having males more than females. The visual acuity at presentation was 0.7 logmer, which is equivalent to 6/30 Snellens. And the duration of onset of visual symptoms, that is visual loss, and the presentation, that is the stopping of ethambutol, was 25 days. On visual field examination, we found out that the temporal field defects are very commonly seen, followed by secocentral scotomas. And the VEP was affected. Basically, the amplitude of VEP was affected, and the latency remains unchanged, or it was minimally affected. And at follow-up, it came to normal. On MRI finding, we found out that there is increase in intensity of optic chiasma level in 20% of the patients, and in about 43% it was normal. So at follow-up, in this chart, we can see there is significant improvement in the visual acuity at 1 month follow-up. The limitations of our study is a sample size, small sample size, short duration of the study. It was a retrospective study, and we don't know the visual acuity at the start of anti-tuberculosis treatment. We compared our results with other studies, and we found out that about 43% of the patients were having bitemporal hemianopias followed by secocentral scotomas. Again, the VEP amplitude was affected in majority of the patients. There is no significant change in the latency of the VEP. Most of the patients was having normal MRI findings, except that in some of the patients we found out that the MRI intensity at the level of optic chiasma was increased. So this finding was correlating with the visual field finding of bitemporal hemianopias or temporal field effects. So what is the confusion? So we discussed our, we found out many series of cases or the result or the papers which showed that there are some genetic factors or the mitochondrial mutations that might be contributing to the drastic effect of ethambutol on the optic nerve. So we conclude that regular screening of these patients is required to screen the disease, to detect the disease at the earliest, and to prevent its visual deterioration. Thank you. It was sluggishly attacking people. Yeah. Yeah. Okay.
And we have to keep a close follow-up for these patients to see again, as madam has already said, that we have to look for the systemic status of these patients. Just to stop with ethambutol and we can't go like that. So it's a serious disease, and patients usually need regular follow-up. So,
see, Pinank, I think this is a very good presentation, and it is a very relevant point that you are trying to make over here. You see the mean presentation time The mean time is 25 days.
Yeah.
Right. So it goes to show that people have been on AKT, they have lost vision and have taken that much time to reach the ophthalmologist to,
So some of the
with the
patients are
complaint.
referred from the physician.
Yeah, I know that. That is what I'm saying. That is why the paper is important, because this paper tries to show that it may be important to sensitize the physicians that while patients are on AKT, if there is that they should sensitize the patients that if there is any slight decrease of vision, it should be reported. So it's taking 25 days for them to present.
Basically, sir, we should screen all the patients, specifically the high-risk category patients, like patients with comorbidities like hypertension or diabetes, or patients on kidney on any kidney supplements or kidney disease. They should be screened before starting ethambutol or ATT.
See, what we've observed in our cases is when they are renal cases, when they are cases of CKD. See, CKD obviously are immunosuppressed. They end up getting tuberculosis many times. When these patients get ethambutol toxicity, recovery takes really long. It takes really long. So that is why this paper is very relevant.
Okay. Thank you, sir. Thank you, ma'am.
Good morning, all. I will be discussing about clinical phenotype and radiological findings of MOG IgG associated optic neuritis, a retrospective study. MOG or myelin oligodendrocyte glycoprotein is a transmembrane glycoprotein found on the outermost surface of oligodendrocytes and myelin sheath, and it found exclusively in the central nervous system. The functions of MOG are mainly myelin fibers adhesion and interaction between the myelin and immune system, and oligodendrocyte microtubule stability. MOG has extensively studied in the past, but only in 2018 it recognized as a distinct entity. And optic neuritis is divided into typical and atypical. Multiple sclerosis included in the typical type of optic neuritis, and NMO and MOG in the atypical type of optic neuritis. MOGAD or MOG IgG antibody associated disease mainly manifest as optic neuritis, longitudinally extensive transverse myelitis, and acute disseminated encephalomyelitis. MOGAD is a distinct clinical entity, and it differs from multiple sclerosis or NMO in both immunologically and pathologically. Different presentations are seen at different ages, and in adults mainly manifest with the optic neuritis. And the diagnostic serum testing is by indirect immunofluorescence. A cell-based assay, it shows fluorescence. And I would like to share our experience with the MOG positive patients. Our aim was to characterize the clinical phenotype and radiological features of MOG associated optic neuritis. It was a retrospective study conducted in our neuro-ophthalmology department for a period of 4 months. We included all patient clinically diagnosed optic neuritis, unilateral, bilateral or recurrent disease, and aged more than 16 years, and those who are willing for serological testing. Coming to the results, out of 72 patients present with the optic neuritis in our department, we included 35 patients and tested for MOG IgG, and 22 eyes had retrobulbar neuritis and 23 eyes presented with a disc edema, and 8 out of 35 patients were positive for MOG IgG. And out of this 8 positive patients, 7 were females and 1 was a male. And the mean age was 31.75 years. And this is the picture showing the visual acuity at the onset of the disease. Most of the patients were within 5/60 and 1/60. 2 patients had PL plus vision. And out of this 8 positive patients, pain on eye movements presented in 67%, and bilateral presentation seen in 50%, and recurrent episode was seen in 16.6%, and 75% had disc edema, and 25% had retrobulbar neuritis. Coming to the radiological findings, in the first image you can see the T2 hyperintensity and contrast enhancement, and it was found in 75%, and perineural enhancement you can see in the third image. It was found in 75%, and intracanalicular involvement was seen in 8 eyes, that is 66%. In the first image, there is hyperintensity in the right optic nerve, And second image, you can see the diffusion restriction. Third image, you can see the post-contrast enhancement. And we treated all patients with steroid therapy, intravenous methylprednisolone 1 gram for 3 to 5 days, followed by oral prednisolone as per ONTT. And we referred all patients to neurologist. And immunotherapy initiated in 4 patients with mycophenolate mofetil. This is the post-treatment improvement in visual acuity. 83% patients improved to 6/6, and this is the visual outcome pre-therapy and post-therapy. You can see most of the patient improved to 6/6, and 2 patients with the PL plus improved to 2/60 and 3/60. Coming to the discussion, this UK study shows that 50% of Mogart phenotypes present with the optic neuritis, and this study by Ying et al. Showing that most of their patients were female, similar to our study also. And in our study, bilateral disc edema was seen in 50% and painful ocular movement in 66%, similar to this study by Dina et al. And in MRI characteristic, there won't be no involvement of chiasma or optic tract in MOG, similar to our study. And this is one of our patient with the NMO positive optic neuritis patient. Here you can see the optic tract and optic chiasmal involvement in NMO. To conclude, introduction of this novel serological testing for MOG IgG and treatment options enabling an earlier, more accurate diagnosis and timely management. This in turn will lead to a better determination of prognosis. These are my references. Thank you.
Interesting data. So because of the facility of tests available and the awareness about this, we are getting mock positive cases quite often in India. The incidence is also increasing. So we should be aware of these cases in bilateral recurrent cases, atypical cases. What was the percentage of cases you need to give immunosuppressants?
We referred all MOG positive patients to neurologist map, but they started only MMF in 4 patients only. Other 4 patients were not willing for this long-term immunosuppressants. That's why neurologist advised all patients immunosuppressants.
All cases with along with IV methylprednisone. All cases need.
They started MMF in all patients, but only 4 were willing to start because of financial constraints and long treatment, so they were not willing for this.
I think IV methylprednisone, if patient responds to it, may not need immunosuppressants immediately. Yeah. I would like to know the.
Next.
Yeah, I think if you get a significant improvement, you don't have to put them on immunosuppressants immediately. Yeah, on follow-up. Secondly, I read some of the papers from North India. 50% of these patients never come back with antibody titer report because it is very expensive, 7,000 or something. Yes, so what is your experience in your center? All of them come back with?
Yes, sir. Our patients were in regular follow-up. And those patients with the financial constraint, even with the MRI report also, we probably think like it can be MOG. Then that patients all will be referred to neurologist.
Thank you.
See, our clinical experience with MOG has been this way, that and it has changed the way we write investigations. Now what we are doing is in patients with optic neuritis, we end up requesting for NMO and MOG titers. Okay, many of them do come back with the titers. When the patient is MOG positive, we as clinicians know that there is a chance of a recurrent disease. Okay, we as clinicians know that the prognosis is better because the prognosis is obviously better than NMO. Okay, the point that madam makes is very well taken, that many patients don't opt for the immunomodulation, but they do not get recurrences. The idea of immunomodulation is to control recurrences if they are occurring.
reports that MOG is not as innocuous as it was thought. So I think a little bit of responsibility on us too, to motivate our patients to go in for the, either the suppressant or the modulation, depending upon whether it is NMO or MOG disease, so that the recurrences and the other follow-up problems that the patients face is brought down significantly. As Sir said, with these immunosuppressants or modulations that we do, the recurrences are brought down, and there are systemic problems involved along with the optic neuritis, which we have a responsibility to think about when we make the diagnosis.
So I agree with what she's saying. We are dealing with a lady who has MOGAD, whom we've thought of all other etiologies, including lymphoma, ruled them out, done biopsy, done everything. Every time she gets a recurrence, there is a 2-line drop of visual acuity. She's now at, counting finger, 2 meter. We've tried almost all the immunomodulators. We've even given her tocilizumab. So I agree with her that while we keep saying that it is a disease with a better prognosis, some cases of MOGAD are extremely recalcitrant. The patient that I'm talking about just now, we've taken, opinions of everybody in India, internationally, but now she seems to be controlled with tocilizumab and 20 milligrams of prednisolone. But 20 milligrams of prednisolone is a lot to give to somebody on a continuous basis.
My topic is to start the high dose of ibmethylprednisolone for aquaporin 4 and MOG optic neuritis is the present dictum for visual recovery and outcome in optic neuritis patient. In other words, wasting time to start the high dose of ibmethylprednisolone for aquaporin 4 and MOG optic neuritis is a blunder for visual recovery and outcome. Previously, as per North American optic neuritis treatment trial, acute treatment of optic neuritis in multiple sclerosis by ibmethylprednisolone accelerates the recovery but do not affect the final visual outcome. Thus shows the sense of non-urgency of the treatment in acute phase of optic neuritis. But with the new era of biomarker like aquaporin 4 and MOG antibody positive patients, watershed line starts. The clinical course of optic neuritis differs from multiple sclerosis, typically steroid respondent, very much steroid dependent, associated with poor visual recovery, visual outcome and recurrences, and poor visual recovery from each attack increases the accumulative disability. The purpose of this study is to find out the role of high dose of ibmethylprednisolone and whether the earliest treatment, that is urgency, that is the minimum time from onset of symptoms to high dose ibmethylprednisolone, results in the best corrected visual acuity recovery after 3 months. First, we go for the diagnosis of optic neuritis by the clinical history and objective finding as determined by the clinical examination of neuro-ophthalmologist and paramedical clinical test. There are some inclusion and exclusion criteria in our study. Exclusion criteria are the other ocular causes of poor vision and the treatment refusal. All diagnosed cases of optic neuritis had also the diagnosis of aquaporin 4 and MOG associated optic neuritis based on the established diagnostic criteria of International Consensus of Diagnostic Criteria of NMO 2015. Aquaporin 4 and MOG antibody tests were done by using commercial cell-based assay. On the basis of the above methodology, retrospective study was performed. Total number of cases 38, in which the 30 are the aquaporin 4 positive neuromyelitis optica and 8 are the MOG positive. The study focused on the visual acuity as a functional outcome only, not the other functional parameter such as visual field and the structural anatomical outcome as measured by OCT. Documentation is done for the age of the patient, sex, antibody group, and the time to start the ibmethylprednisolone in days, and best corrected visual acuity at the time of first reporting. Best corrected visual acuity at the time of 1 month and 3 months are also recorded. At the time of presentation, even if the antibody status was not known, urgent ibmethylprednisolone start at daily dose of 1000 milligram for 3 to 5 days, followed by the oral prednisone 1 milligram per kg per day for 11 days, and then taper off in the 21 days. Oral prednisolone treatment was prolonged in cases of relapse or in case where it is suggestive of acoprin 4 and MOG antibody diseases. These are the study of the data of my study of all my patients. Here the antibody status was taken, and this age, sex, and the start of the IV methylprednisolone days, and one at the days, and 1 month, and after 3 months. This is a distribution of best corrected visual acuity 1 month for the patient treated with IV methylprednisolone. Here the patient treated within 7 days is better than the patient treated after the 7 days. So the earliest treatment is better. Is the distribution of best corrected visual acuity at 3 months for the patient which treated IV methylprednisolone. Here again, the best corrected visual acuity in the patient treated within 7 days is better than the patient treated after the 7 days. This is a ROC curve analysis of the failure to regain Snell 6/6, and here the dependent variable are the failure to regain Snell 6/6, and here the predictors variable are the cutoff time to IV methylprednisolone shown in the blue line, and age of the patient in the green, and the best corrected visual acuity in the red. Here the area under the curve, when they consider the treatment days of the treatment alone, is very high than the age of the patient and the best corrected visual acuity as shown in green and red line. Even all the parameters are combined, predictors are combined, even then it is not better than the day of treatment alone. And also the Uden index for the best cutoff time to IV methylprednisolone here is the 7 days. In our study, the patient with acoprin 4 antibody and MOG positive optic neuritis respond better with the early start of IV methylprednisolone. And if it is less than 4 days, the visual recovery is excellent. If it is in between the 4 days and 7 days, it is good. But after the 7 days, it is not so good. This, if we go for the relevance of this study, the pathogenesis of optic neuritis timeline, the progressive retinal ganglion cell layer loss can be observed as early as 8 days after the onset, but irreversible axonal cell starts within 5 days or 7 days. So optimal treatment should be started by 4 days, but the treatment before day 7 still offers opportunity for good visual outcome. This pathological finding supports the clinical finding of this study. The conclusion is to start the IV methylprednisolone earliest within the few days of optic neuritis, as the time is the tissue in the core principle of neuroimmunology. These are my references. Thank you for patient hearing.
Excellent presentation. In the interest of time, we are going to cut short on the discussion, but I think it's a very good take-home message from your presentation that we need not, in the current era.
I'm a ophthalmologist. I'm not neuro-ophthalmology. So every cases, I just when I did the diagnosis of optic neuritis, then I refer the patient to the neuro-ophthalmologist and neurology department. Then they already, when those these investigations are covered, then we follow up those cases. And cases generally in our ophthalmology solo practice, the patient comes after 6 or 7 months. But here, if we follow up this with the investigation, it is better. The results are far good if it is start with the treatment earliest, without any hesitancy.
Okay.
Thank you.
Thank you. Thank you very much. So we'll like to invite Dr. Chinmay Mahatme. Is he there? Yeah. His talk is on macular, microvascular and structural changes in NMOSD and MOGAD.
Good afternoon. I am Dr. Chinmay Mahatme, and I'm here today to share with you our findings regarding macular, microvascular and structural changes in neuromyelitis optica spectrum disorders and myelin oligodendrocyte glycoprotein antibody disease. So, I have no financial disclosure or conflicts of interest to declare. NMOSD and MOGAD are both demyelinating disorders of the central nervous system with common clinical presentation. It can be tough to differentiate these in the OPD, and serology can be expensive, unavailable, and time-consuming. The two conditions have different prognostic implications for the patient and slightly different management approach in the long term. Another way to look at these demyelinating disorders is to study the vascular changes that occur in them. Hypoperfusion and predilection for watershed areas is already well established in multiple sclerosis. Even in NMOSD, vascular mechanisms are hypothesized to play a very important role, especially considering the fact that the aquaporin 4 receptors are expressed in the perivascular foot processes of the astrocytes. However, the chronology of these vascular changes is not clear, whether they are causative or secondary to the neurodegeneration. So where can we study these vascular changes? In the retina, of course, because it's the most accessible vasculature of the central nervous system. And how can we study them? With the advent of optical coherence tomography angiography, we can study these microvascular changes non-invasively, with great convenience and in great detail. So we aim to study and describe the macular, microvascular and structural changes in an MOSD and MOGAD using OCTA. And we wanted to evaluate the role of OCTA in the clinical approach towards the evaluation of these diseases. This was a cross-sectional observational study at a tertiary eye care center in southern India. The diagnosis of these conditions was based on serological testing, and we had 8 NMOSD patients, 17 MOGAD patients, and 10 healthy controls. We used the Zeiss Cirrus 6000 angioplex system for obtaining the OCTA images, and we studied macular vascular density to represent the microvascular changes and the ganglion cell plus inner plexiform layer thickness, or the GCIPL thickness, to represent the structural changes. The average age distribution in the 3 groups was around 37 to 40 years. Majority of the NMOSD patients were female. MOGAD had an equal gender distribution, and 70% of the controls were females. All of our NMOSD patients were unilateral in terms of presentation. MOGAD had an equal unilateral and bilateral presentation, and this did not apply to the controls, obviously. There was an average interval of around 3 months between the onset of symptoms and the OCTA imaging in our study, and NMOSD had a poorer presenting visual acuity and a poorer visual recovery as well. When we look at the macular vascular density, this graph clearly shows us that NMOSD and MOGAD patients had reduction in macular vascular density in the unaffected eye as well. When we look at the structural changes in terms of GCIPL thickness, we see that the NMOSD and MOGAD patients had reduction in the GCIPL thickness or GCIPL thinning majorly in the affected eye and not so much in the unaffected eye. The t-tests that we carried out for NMOSD and MOGAD groups reflect what we just saw in the graph. But when we compare NMOSD and MOGAD head to head, we do not find any statistically significant difference in the macular vascular density or the GCIPL thickness in either the affected eye or the unaffected eye. So what do we take from this study? That there is reduction in the macular vascular density even in the absence of GCIPL thinning. And this correlates with what we have seen in multiple sclerosis as well. In a study conducted by Montorio et al., they have seen that multiple sclerosis causes progressive thinning of GCIPL with, progressive reduction in macular vascular density without significant thinning in the retina. So more insight into these mechanisms and the chronology of same is needed. Lang et al. Have conducted a study recently on this very topic where they did actually find a difference in the GCIPL and macular vascular density in the 2 groups, which might be used to differentiate them on a clinical basis. But as far as our study is concerned, we conclude that we cannot reliably use OCTA yet to differentiate these 2 diseases. However, what we noted was in case of unilateral presentations, if the other eye showed both GCIPL thinning along with macular vascular density changes, then MOGAD was more probable. We were not able to highlight any subclinical contralateral involvement of the other eye yet. And we've only involved the superficial vascular plexus in this study. This was a cross-sectional study design, so we don't have any data to show the chronology of events. And we cannot justify the rationale for what changes we are seeing, the macular pathophysiology. And we still need a larger sample size. So what is next? If we are able to delineate the chronology and the exact pathophysiology of the vascular changes in these autoimmune demyelinating disorders, it may provide very valuable insights into the diagnosis and management of these diseases. And if OCTA can play a role in identifying contralateral subclinical involvement or seronegative cases, it will be of great value. These are my references. Thank you.
Thank you. Nice presentation. With the availability of OCT and OCT angio, nowadays lot of studies are coming out.
Yes.
And I think these studies, I mean, these findings may not be diagnostic, but definitely they will help us in the diagnosing these cases as a aid to our other diagnostic methods. And I think they will be more important for from prognostic point of view. Maybe follow up if you see those cases, again repeat the OCT.
Yes.
Maybe we find the change in vasculature improvement or something like
Yes,
that.
ma'am.
So definitely long-term studies are needed.
Okay. Thank you. ma'am.
Yeah, nice presentation.
Thank you, sir.
We need, I think, more studies to come to definitive conclusion.
Yes, sir. Definitely.
It's a very nice pilot study. I think gives a lot of ideas.
Yeah, okay.
Very nice.
Okay.
Thank you for presenting.
Thank you so much. Yes, ma'am. Sorry for the confusion. With the Zeiss Cirrus Angioplex 6000 system, we have two ways to look at the macular vascular density. First is in millimeters. It gives the central macular vascular density in terms of millimeters per millimeter squared. And there is also an ETDRS perfusion index. So in this study, we have used the millimeters per millimeter square data that was available. I'm not sure how the ETDRS perfusion index exactly is calculated, but yeah. Superficial vascular plexus, yes, because we did not have adequate data for all patients.